Good morning. Welcome to Grand Rounds. My name is Suresh. I'm with the Divisions of Health Informatics and Emergency Medicine. It's my pleasure to introduce our Grand Round speaker, Dr. Lindsey Knake, this morning. Dr. Knake is Associate Professor of Pediatrics and Associate Chief Health Informatics Officer at the University of Iowa. Dr. Knake studied biomedical engineering as her undergraduate degree and has used that skill set to transition to an expert in clinical informatics. She completed her pediatric residency at Texas Children's Hospital and her newborn medicine fellowship and a simultaneous master's degree in biomedical informatics at Vanderbilt. She is the current EPIC Neonatology Steering Board Chair that provides advice to EPIC on the needs of neonatologists. Lindsey is the chair of the EHR integration subgroup of NeoMind AI, which is a new group of neonatologists interested in applying machine learning and AI capabilities to advance neonatal care. She has both an operational role and research interest in utilizing electronic health records to improve patient care and enhance clinician satisfaction. Her current research explores how AI can create models based on continuous data from bedside vital signs monitors and ventilators. She's currently developing a model to predict neonatal extubation success. She has been utilizing EPIC's Cosmos database to study outcomes of infants at the limits of viability. I've had the opportunity to listen to Dr. Knake's presentations at various informatics conferences, and her discussion today on everyday AI for busy clinicians is very timely and will be valuable for us as we transition to a new EHR platform here at Children's. Without further ado, Dr. Knake.
Thank you, Suresh. Right. And thank you, everyone, for coming in person and online for this talk. This is great. So today, just kind of briefly, some of the learning objectives. We are going to just talk a little bit about math because I think it's important to understand some of the background and basics of AI and how this works. But really, then I'm going to try to focus on some more clinical use cases. And I'm hopeful that everybody will be able to take away something from this talk that maybe you can even start using or trying tomorrow. And since I knew that the EPIC transition is looming soon for you guys, we will have some different EPIC tips and tricks callouts that I've picked out over the years, as well as talking about EPIC's big de-identified database, Cosmos. So disclosures, I am on the board of directors for NeoMind AI, which if you're a neonatologist, let me know. Please join our group. I think it's a great collaborative group to learn about more AI practices in research and clinically. I don't have any financial relationships to talk about, but you are going to see a lot of generated images from all the various large language models I use, such as ChatGPT, Claude, Copilot. Some of them I've put on actually the date and the years that I've created these images because you can see how they change and have advanced over time as well. So the first question you might ask is, why are we talking about AI? What is this new technology? And I'm sure many of you wear as many hats as I wear on a daily basis and doing a lot of things. And really, I think using AI is our next best efficiency tool to help us manage all these jobs and roles that we're doing on a daily basis. Here's just another example of Napkin AI that can create images for your talks or your presentations, slideshows. Instead of spending hours in PowerPoint creating that perfect image, right, you can just put it into a large language model to try to help you save time. Many of you might be thinking, is AI really worth the hype? We've been hearing about this for a while. And I will say, when I started giving these talks a couple of years ago, I think I had to do a lot more convincing people it's here to stay. Please try it. It's not evil. And I think we're finally getting in this hype cycle more into the slope of enlightenment, where people have realized, what can I really use AI for? However, similar to this meme that one of my colleagues sent me, corporate America, some people are getting tired of AI being dumped down their throats of use it for efficiency, you must use it for everything. And I definitely think it's not perfect for everything. It's not replacing our jobs. It's not replacing people. But how can we utilize it to be more efficient and help decrease the burnout that we're feeling in medicine? So now we're going to just start with some definitions of what is AI. And with these definitions, I have to start with biomedical informatics. And it's not just because I did a master's in biomedical informatics and I want people to understand that, but I think informatics is a term that some people haven't heard of or don't completely understand. So informatics is a field that's been around for decades. And in 2009, Dr. Friedman kind of coined this image where, human plus computers is better than humans alone. We still don't think that computers are going to be replacing humans, but we're human. We make mistakes. How can we use computers to remind us or, put some guardrails around some of the clinical guidelines we need to do? But biomedical informatics is really an umbrella term that can cover a lot of different things. The first image I have up here is more like bioinformatics. So anybody who does genetic or genomics research, that's a whole field of big data science that uses a lot of AI and machine learning skills, but is something I'm not necessarily an expert in, but could definitely be a field of biomedical informatics. Imaging analysis is a huge area in biomedical informatics and is actually some of the most advanced tools we have is in imaging analysis. And I think it makes sense because if you can imagine, images are basically grayscale from 0 to 1, which computers can understand better than humans. So you'll see that some of the most advanced FDA-approved technology is really in imaging informatics. And then we get into more of the clinical informatics stuff that we deal more on a day-to-day basis. Data interoperability. How do I get my Apple Watch, my automated blood pressure cuff to speak to the EHR and send that data back to us? How do I get analytics on what's happening on my patients or using machine learning to create predictive models? Or how do we develop clinical decision support into the EHRs? So lots of different things under this biomedical informatics umbrella, and you'll have different specialists in different areas. Okay, moving on to the next definition of artificial intelligence or augmented intelligence, which is what people call it sometimes. So AI really isn't new, although it seems new in the past couple of years, but really AI has been around since the 1950s. And the first example of that is automated EKG reads. All of us went to medical school and learned how to read EKGs, but we still do get the automated reads to help double check things, to understand if you're, out in the community, you haven't read an EKG for a while, it's going to give you, some basic reading of that. However, machine learning has advanced a little bit more since the 90s and 2000s. One example of machine learning that we're all probably familiar with is your Netflix algorithm. That's a basic random forest algorithms that's saying, you like this movie, I'm going to keep telling you movies similar to this genre of what you might want to watch next. So something that's been around forever that we're all very used to. But generative AI is really what's been new and has jumped on the scene to kind of jumpstart us into this big AI kick in medicine. And was really made popular by ChatGPT releasing its free model for everybody to play with. And generative AI is developing language or predicting what's going to come next, which we'll talk about in a second. But as you can see, FDA-approved AI algorithms have been accelerating since 2017, really going up. However, the red line is pediatrics. So as per usual, in pediatrics, we're a little bit slower and a little bit behind the research of making sure things are safe for our patients. But really areas that it's been advancing for decades has been radiology. So again, with that imaging informatics being the most advanced, many radiologists are already very used to having the tumors outlined for them to double check in various versions of the software. For decades, people have been saying AI is going to replace radiologists, which we haven't seen any of that yet. It's really been more efficient in helping radiologists, again, be more efficient and do their job and making sure they're not missing anything that could be outlined as something that just may need to be double checked in incidental findings. Other big areas that have FDA-approved algorithms, cardiology, neurology, hematology, GI, ophthalmology. So a lot of, again, very imaging-based algorithms so far. So you may ask me, but is it actually implemented in clinical practice? I was a part of a group that we did a review of some of the literature on this recently, and this was pre-generative AI. But we found out of the 126 articles, only 14% of them have actually been implemented in clinical practice. The joke I usually tell is now with large language models such as Claude Code, or you can use Codex, other versions to help you code. Anybody and their brother can make a predictive algorithm at this time. But the real difficulty is how do we implement this and how do we get it into clinical care? So I think really that's the arena we need to start focusing on. And you can see this in this review article in the NICU and the PICU. So many models and prototypes are being developed here, but getting down into the implementation and into the clinical phase is really the difficulty. And I think where us as researchers need to kind of focus on and go to next. Okay, we're going to talk a little bit about math. Not a ton, but just a little. The engineer in me comes out. So if you remember back to learning about linear regression or logistic regression, really it was about finding those data points with the best fit line. You broke it down between males and females, what's their BMI, what's their age, but you're really trying to find that best fit line for your beta coefficients, for your odds ratios. And so really we've been doing, math-based research for a long time, but it's getting more complex now that we have more machine learning options to other than just logistic regression. You could move to something like simple decision trees. So again, this is kind of similar to those Netflix algorithms of random forest or gradient boosted trees, which you may read or see in some papers. But this is saying that the problem is not always linear. How can we break it up into different buckets? And can I fit into these different decision trees? So it can actually make interpretability a little bit easier for clinicians. But as many of these algorithms have, there's always risk for overfitting your data, or meaning you make the trees perfect for your training data, but then it doesn't work for real world or external databases that you need to test it on. More complex machine learning gets into neural networks. So convolutional neural networks or different varieties of those. That's what a lot of that imaging AI or predictive models are based off of. And the reason it works well for them is because it allows you to do large matrix maths for things that are not really just linear problems. However, you can see with this simple neural network, there's a lot of hidden layers there. And that's how you set up the matrix math, is that you might have multiple hidden layers. And what the algorithm is trying to do is try different weights for all of those arrows to see what's going to be the best fit to predict whatever output you're trying to predict, extubation success versus failure, and how many inputs do you put in. But this is where, even as an engineer, the matrix math gets hard for me, and I have to really dust off how do I multiply and do that matrix math again. But this is where it gets harder for clinicians to really understand what's inside this machine learning model. And this is where you get that black box approach, because it's not as easy to understand the beta coefficients or understanding the weights of these models. But many people who trust these models say what matters more is the output. Are we able to predict the output just as well as clinicians, if not better in some cases? But it is still important to validate and make sure you understand how these predictions work. So as with any prediction models, I like this image because really to make sure that they work, 80 to 90% of the time does have to be about making sure you have, the appropriate data in. Otherwise, you're going to get garbage in, garbage out. And then that's where we come in as clinicians, that we really might need to partner with data scientists or the people making these models to make sure the correct clinical data is getting in. It is cleaned appropriately. It doesn't have errors. The machine learning model isn't, learning on things such as an imaging analysis. The joke is that the X-ray model always works when it has an arrow pointing to the arrow sign on the X-ray. You need to make sure your machine learning model is not just learning this is abnormal because there's an arrow there, but what is it truly understanding? So that's where, while the coding part is easy, the model development is easy. Us as clinicians who have the data and know the good inputs and outputs really need to work and partner with the data scientists. And I put this table on here not for you guys to read it and understand and digest everything, but for just as a reminder that in the machine learning and predictive modeling world, there is going to be new vocabulary that we need to learn. So in looking at metrics, there's not really one perfect metric to say that we always should look at positive predictive value, sensitivity, specificity. Depending on the question, it might be different. And the new metrics to learn about and think about are going to be things like F1 scores or areas under the precision recall curve. And I say that because while you're reading these new papers, I think it is important to learn this new vocabulary and look at it and evaluate this, because things like F1 scores and AUPRCs are really important for many of the models we're trying to predict, where you have imbalanced data sets, meaning that sepsis is an overall rare event. We keep trying to predict it, but your positive predictive values are always going to still be fairly low because it is an overall rare event. So taking an opportunity to, as a reviewer or reading the articles, to make sure that you're not just putting all of your eggs in one basket for the outcome metrics, but evaluating at many of them. Okay, moving on to large language models and ChatGPT. So we just reviewed some of the math about how the other prediction models work, but really how large language models work is they're predicting the probability of what's the most likely next best word that us as humans would like to see. And, it's learned on all of the data in the internet. And similar to what we just talked about in other prediction models, it's garbage in, garbage out. You have to understand, where are some of these models getting data, or what are they learning on? So that's why something like open evidence, which we'll talk about more in a few slides, which is learning on all of our medical literature, New England Journal of Medicine, the American Academy of Pediatrics guidelines, those predictions and what it's trying to tell you is trustworthy as physicians, because we know that the corpus of data it's learning on is really, really powerful. One example I have, and this is actually an old slide now because we've stopped doing these tests, because you could see a couple of years ago, ChatGPT 3.5 only got 45% of our, board review, our neonatology board review questions correct. But then very quickly, 6 months later, they released ChatGPT 4 and it got up to 70%. We've stopped doing these tests because we're now on ChatGPT 5.5 and it can quickly outpace and get all the answers correct because it's been learning and continuing improving on these models. So just showing how quickly and how powerful these models are improving and advancing in our medical area. Which means that we should actually use it for things like our literature reviews. Here's 3 examples of different applications or apps that you maybe haven't explored yet, but you could explore. I haven't actually used Research Rabbit recently, but it's, if you like the more graphical view of what articles all go together. I've used Consensus to help me in writing review articles, coming up with outlines and making sure I don't miss review articles. I still read the articles and make sure they're articles that are appropriate, but help getting me started and what should I do with my reviews. And then open evidence is definitely the biggest large learning model that if you haven't used as a clinician yet, you really should. The most recent report is that over 50% of physicians in the US are already using open evidence. It's free to everyone currently. You just have to have an NPI to sign up. And this is where open evidence has recently partnered with all the big academic societies, American Academy of Pediatrics, Family Medicine Societies. So all of our guidelines are going into open evidence. And if a medical student asks me how to research something, a lot of times open evidence is what I'll encourage them to start going to first. I still encourage them to click on the articles that open evidence gives you, because I still think it's important to understand the primary literature. But you can't see in this screenshot, but this example was, I did a test with one of my fellows and I said, oh, there was an article in neonatology talking about if you give caffeine spread BID instead of daily, what's the outcome of those babies? She spent a long time in PubMed trying to find this article, couldn't find the one I had asked her to find and read about and report back after rounds. I said, why don't you try to find it in open evidence? And within seconds, it pulled up the exact article of what I told her to research and look at. So PubMed is great, but if anybody else has struggled in finding what you want in PubMed, you have to know the keyword, the author, what year was it. Open evidence is so much faster and easier in using language to find what you might need. Okay, shifting gears a little bit into talking about ambient AI for people who may or may not have tried it yet. We'll see if I convince you to give it a shot. So what is ambient AI? This is, AI scribes, or when you have a listening device on your phone or computer that's going to be drafting and writing your notes for you. So this is one of the fastest growing technologies in medicine, which is funny because traditionally in medicine, it's very hard to get into this space and get physicians to trust something. But this technology has grown very rapidly over the past 3 years without very many randomized controlled trials, without any true studies. And the reason being that physicians were hungry for something to help them stop writing notes at night. How can I be more efficient? How can I, stop my pajama time and spend more time with my family? So there was one of the early 2025 multi-center QI studies on this area did show that there was decreased burnout in physicians who use ambient AI. There was decreased cognitive load and decreased documentation time. Now, mind you, it only saved you about 10 minutes a day because it's still not perfect. You still have to edit it and review it and make sure it's saying what you want to say. But physicians were willing to use it, even though it only saved them 10 minutes a day, because of that decreased cognitive load. I don't have to write notes on paper anymore. I don't have to forget something. I don't have to worry. They have a true transcript of what was being recorded in their conversation with the patient that they can go back to at any time to help them review that. There was eventually a true randomized control trial. It was actually a very good one, a cluster randomized control trial that came out in 2026 that showed very similar findings. Still not saving tons of time, but decreased 16 minutes, decreased 13 minutes of EHR time. And some clinicians were actually, while most hospital systems, this isn't the expectation, but some clinicians are willing to add more patients in because they aren't overwhelmed and overworked all the time. It's funny, when this first came out, physicians were very much like, oh, ambient AI is just going to be the administrators making us see way more patients. And what I would say as somebody who's kind of, I'm not in charge of those decisions in my administrative role, but what I've seen is the hospitals have realized how much money they lose and physicians burning out, clinicians leaving, them have to hire new people, that it's really not the expectation that you have to see more patients, but it's trying to help decrease the burnout and the cognitive load so that you're happier and more fulfilled in your career. And what's interesting is who this benefits the most. As you can see that in this study, they found primary care doctors, obviously, because this is outpatient clinic, and that conversation is really what this tech was developed for. But the highest users, the people who use it the most, get the most efficient at it and save the most time, as well as female clinicians. We have so much to do, so many hats to wear at home. We don't want that pajama time. I have a 4-year-old and 2-year-old. I cannot do notes at night anymore. Using this to be more efficient is really helpful. Okay, so what was our experience at the University of Iowa? This is just data on our pilot data when we went live with the trial of Navla, which is I think only about 30 clinicians. But we did the pre and post burnout scores, and you can see those clinicians who did use Navla, which is our ambient AI, did have decreased burnout scores. And what you can see here is that the highest quartile, and I have this here on this side, the highest quartile did have the most decrease in burnout scores. So again, the people who use this technology the most found it the most beneficial and had the biggest decrease in burnout scores. So again, if you've tried this once and you said, it's not for me, I didn't like it, you really have to learn the tips and tricks like any new technology. And there's ways that you can customize it, give it the correct prompts to work for you. So I just encourage you to try it again and see if that it can help decrease your time or cognitive burden. The other thing that we did, which was interesting, is we partnered with our qualitative group to actually interview people who were a part of this pilot in using Navla and said, what did you think about using Navla? What did you like about it? And my favorite quote is when they talked about, I get to make eye contact with my patients again. I grew up in a time where you have to write your note, you're looking at the computer, you're getting everything down, but having a few minutes of rest in your brain to not have to write down the notes and make eye contact with your patients, it's wonderful to see clinicians get that joy of patient care coming back. They do acknowledge that the way the large language model says it isn't maybe my voice, not the exact words I would choose. But in the interest of efficiency, many of these providers are okay with that trade-off because they want to get their time back and they want to have that decreased burnout feeling. So ambient AI use cases that I use on a daily basis, and remind you, I'm a neonatologist in patient care, so I'm not a family practitioner. I'm not doing that outpatient conversations, but even in inpatient, we have a lot of conversations. Complex family care conferences. I've used it with an interpreter, with 5 subspecialists, with the dad sitting in the corner mumbling, and I thought there's no way it's going to pick up what the dad says. And on my phone, this ambient AI listening device picked up everything. It works phenomenally, and I still go back and edit it and say, this pulmonologist said this ENT doctor said that, but having something to edit and a draft, it picked up and captured more things than I would have spent the time as a clinician writing that after that hour-long care conference. Sitting in a care conference for an hour, it's hard to document everything that's being said, but ambient AI can truly help you do that. We've used it for transport phone calls. It's a little bit more difficult sometimes if you have to do speakerphone to speakerphone, but again, it's unstructured notes of what did that outside provider say to me? Can I help accurately document this or get the transcript of what was truly said? And then for us, for prenatal or follow-up consults for families or complex congenital anomalies, it's been really useful as well. Now you might say, well, what about inpatient? That's most of what you do, Lindsey. It is true. I do a lot of inpatient rounds. And I'm from an Epic institution. I'm a physician builder. So I've highly templated my Epic notes to be perfect and exactly to how I like them. So ambient AI technology is even a little bit difficult for me to adopt and learn something new and to change. But my note template, 98% of the time says no acute events overnight. That baby had to get chest compressions or needed a, reintubation for me to actually probably change something or write something in there. But when I turned on ambient AI during my rounds, there was actually a lot of changes that happen overnight that I just don't take the time to document or put into my notes. So this is just an example of, could I use ambient AI to actually improve my notes and put more information in there than I ever spend the time of doing and talk about all of those fluid changes that really do happen for those tiny babies overnight? This is the example over here. I should have put on the right, your left of the screen is what the ambient AI did for one of my notes. And you can see here, it talked about the 3 problems that we talked about on rounds. My baby had respiratory failure. We weaned their high flow or their RAM cannula. They still have slow feedings. You know, we check residuals. We're talking about increased feeds and they're still on caffeine, but not having any events. This is my highly templated Epic note here on the right. And you can see I personally put in a lot of things like head ultrasound on day of life 7. We can't forget about this, right? And this is just templated copy forward that I put in every day in my notes. So for me to use the ambient AI notes, I would have to accept different notes, or is there different ways that I should put these reminders in, or is it a hybrid of I take, you know, this half for these 3 problems that we're actively doing today and maybe just keep my reminders at the bottom. So I think in inpatient, these technologies are still getting better because at least we're from an institution who does a lot of copy forward, because for our babies who are there for months, sometimes day to day doesn't change as much. So we copy forward a lot of the plan because it's the same. But will these technologies adapt to understand copy forward, keep some of the stuff we don't talk about, and or do you do a hybrid of the 2 where I keep some of the templated stuff in my note maybe at the bottom, but then put in the active problems that we talked about for the day using ambient AI. So I think there's a lot of opportunities for us to figure out how to use this inpatient. It might just be different in us being okay with change, which is hard for everybody. Even as somebody who changes my job, it is still hard for me to say, can I change this note template I've spent so much time creating? Okay, moving to the next big topic for AI, medical record summarization. So although I'm from an Epic shop, we're going to talk about Evidently, which is a third-party company. And this is a Smart on Fire app that you can see that we actually integrated right into our Epic. So it has its own activity tab in Epic. And what this is we went live with this inside Epic because we felt that Evidently had a better product than Epic does at this moment in time with its AI capabilities. And what it does is it can give you patient highlights or summarizations, but it gives you all these medical record summaries that you might want. Patient 2-liner, my last encounter from a year ago, what was the last ED hospital encounter, since the last PCP visit for this patient. So there are lots of different type of summaries that it can generate. And I've used this, for example, also for prenatal consults, because the most powerful thing about this is it also does all the media tab. So those scanned in documents from other hospitals, Care Everywhere in Epic, which Epic Care Everywhere means you're from another Epic system and you had labs somewhere else. So all of these little E's of this prenatal consults where glucose is from different hospitals. This is from a hospital in Illinois, and they came to our care at the University of Iowa. So really powerful tool for me to chart review, you know, labs and records from other places. What's nice about Evidently, because some people might say, "Ooh, I don't trust it." And there was a patient that transferred to me at 6 months of life, you know, transferred from another NICU to our NICU, and told me that the patient had abdominal surgery. And I'm like, "What do you mean the 6-year-old had abdominal surgery?" And I didn't trust it. Sure enough, you could go to the source notes, and I went to the source notes. This isn't that example. This is a pediatric kidney transplant example. But I went to those source notes and found that that baby did have an abdominal surgery that wasn't given to me in my handoff because that was a long time ago. But what's really powerful about this is you can actually, if there's something you don't trust, you can jump to the source and read it. And sometimes stuff you find isn't true. And it's not true, but somebody actually did write it in the chart, right? So the summarization is only as good as what's actually written in the chart. But then you can jump to those notes and kind of double check the sources. What I really like about Evidently is also the even better, more interactive AI features. So this is the example of chat, just like ChatGPT and large language models. Instead of me getting those summaries, I can chat with it. Hey, help me find that last glucose. Help me find, did this patient ever have abdominal surgery, right? It can help you with a chat version of this. And then the other very powerful tool in Evidently, which you can see on this chart over here, is what I've done in the NICU for those 6-month-old patients. I've given it custom prompts. I said, please make a table of all the antibiotic courses this patient has received and look into the notes about why they got those antibiotic courses. What did the clinicians document in the note? What were they thinking? So I can quickly make a decision when my patient gets sick and needs another septic rule out. What antibiotics have they seen before? Why? What have they been positive with? I'll still go in and double check the blood cultures myself and the positive ones. But for the patients who they got, 7 days of cefepime for I don't know what, I can quickly see in this note, somebody was presuming they had pneumonia and they had an elevated CRP, so they got treated at that point in time. So I found this really useful in getting custom prompts to make tables or get specific queries answered that I might want. With this chart summarization, it's also doing things like drafting H&Ps, drafting progress notes, drafting discharge summaries for you. This is an example of one discharge summary I was playing around with, and it was in the bullet point, but you could make it prose format. And some of the comments people might say, oh, it's maybe as good as an intern discharge summary. It's not perfect, but is this better to edit from instead of me starting from scratch? And will it pick up on things we've missed? And I've definitely found it pick up on things we've missed because our discharge summary templates don't generally have, bilirubin information in it because most of our babies discharge at months of life where we don't care about bilirubin anymore. But sometimes we do have those quick turnaround patients that they forget to add the bilirubin information in. So sometimes the ambient AI will remember and add it in where us as humans have forgotten. So while in the NICU, I still recommend that you start your discharge summary early for the babies who are probably going to be there for months and months and months. But I do think these AI summaries could be really helpful for those quick turnaround patients who are maybe only there a few days or a week that nobody had ever really gotten around to starting that summary. Still, you need to review it and edit it, but something that's really helpful to get your residents or trainees potentially started. Okay, so how this has been integrated into the EHR, and we're going to talk a little bit about some of my Epic experiences as well. So I just spent time talking about Novel and Evidently, which are our third-party apps. But last UGM user group meeting, which is Epic's big meeting, Epic had announced their suite of all new AI technologies coming out. Art is their new scribe or kind of their chat assistant. So similar to what I showed in Evidently, they have a chat assistant, which we're getting ready to pilot and try out in Epic soon. Emmy is their patient-facing chatbot. Epic has like cute names for everything. You'll get to know that. But Emmy is their patient-facing chatbot, so that you could chat with my chart about things, so the patients can ask questions. And Penny is their revenue management assistant. So we're getting ready for UGM. That's in August of this year. All new AI things are being announced and being rolled out in Epic very quickly because they're understanding that there's a desire for this from all of their customers. So we did turn on Epic's inpatient insights. So I just showed you Evidently's chart summarization. This is Epic's version, which actually did a pretty good job in the NICU. And it has similar features in that you can see it has the notes. I could jump to the notes and the resources of where did this come from, who said that. You can give it feedback because it's not perfect. You still want to give it feedback and tell it what it did wrong, what did it miss. And you can still generate summaries, discharge summaries, hospital courses, drafts from all of this as well. So Epic's features are improving and they are there. However, we still have Evidently the third-party company because we feel like they're still a little bit more advanced because of those custom summaries and some of those chat features we have. Will we eventually move to Epic's solution because it's cheaper? Maybe. But it's sometimes hard for Epic and these big hospital systems to catch up as quickly as the smaller third-party, more agile systems can. Okay, moving away from a little bit of more fancy large language model AIs, I'm going to talk about some of the more basic Epic things that I found as an Epic physician builder and the neonatology steering board chair that I think are really helpful. In the NICU, we have protocols for everything. So this is a screenshot of all of our NICU order sets. Because in my mind, the best way for people to follow my NICU protocol is I tell the new resident, the new nurse practitioner, whoever showed up, there's an order set for that. Click on that order set, follow the order set. And then what I've done in these order sets, this is an example of our post-op mild pain algorithm, is we actually link our protocol in those order sets. So those new trainees can link out to it and read what is the protocol, why is the protocol. But for the people who don't actually want to click on the links, we also put in this red help text at the top to say, this is the example of who generally follows into our mild post-op pain, the G-tube kids, the hernia repair kids, right? So I put some extra additional red help text for the people who haven't read the full protocol. So ways I'm trying to build this into the order set as clinical decision support. Other ways of clinical decision support that I use all the time as an inpatient doctor is our patient lists. So I live and die by my patient list. How many patients do I have to see today? What bed are they in? I don't have the whole shot of everything on my patient list, but I generally have what's their main diagnoses, what's their gestational age, what's their birth weight, what's their weight today. And so one thing that I built in our patient list was, when does our PICC line dressing change need to happen? This was a protocol we had in the NICU where our nurse practitioners, after 48 hours, they were supposed to do the first PICC line dressing change. And it was actually, when I first came to Iowa, it was a pop-up alert. And as you can imagine, when you're pre-rounding in the morning and it says, do your dressing change, everybody hated it. They're like, no, I'm not doing this now. I can't get to it. So this is an example where we found that moving to a non-interruptive alert, moving to a reminder just on the patient list that, hey, this one's overdue, this yellow one is getting ready for to be due, this green one, it means you just place the PICC line so you don't need a dressing change yet. People could actually prioritize their workflow after rounds. They could look at their list when they're writing notes, putting in orders, and be like, okay, now I have time to remember to do that PICC line dressing change. Should I do this now? My patient has turned red. So this is just another example of how patient list clinical decision support can be really powerful. And then here's the example. And actually, this is probably one of my patient lists. You can see a lot of what I have code status in here. What is the weight of the baby? But this is the example. What I wanted to show was this scoring system, as you can also put scoring systems in. And these are did I write my clinical notes for today? Did I drop my charge capture for today? Did I do my billing? So all sorts of clinical decision support I build into my patient list. Did my patient get RSV prophylaxis? In the NICU, that's really important. I need to remember, did I talk to the family, convince them they should do RSV prophylaxis? And this is our scoring tool. We have built in NSOFA, Neonatal Sequential Organ Failure Assessment Score. It's not a perfect score, but what I use it for is an acuity score. The red one meaning how many pressors is this baby on? How low are their platelets? How sick are they? If I'm coming in call at night, I can quickly see who are my sickest patients, and you can see how their scores have changed and increased over time. So lots of opportunities to customize. Unfortunately, a lot of this stuff is customized. The good and the bad about Epic is you can build a lot of your own clinical decision support in, but I've been able to customize and build these things into our EHR. However, there are a few things out of the box that you can turn on and get from Epic immediately. This is an old screenshot of all the Epic prediction tools that were available. You can see in pediatrics, there weren't as many. Pediatric early detection of sepsis. There's a few more since then. However, I will caution you, while I'm an Epic fan, I've used Epic my whole life, their first sepsis model got a lot of really bad press, and that they validated it in a few big hospitals, but at Michigan, when Michigan compared it to their sepsis scoring, they really didn't feel like it performed well. So that's my caution in saying, if you want to turn on some of these out-of-the-box Epic prediction models, you really have to try to understand, will it work for your patient population? Is it finding what you need it to find? And maybe do some, silent testing first before you turn it on and get a bunch of alerts that your clinicians don't know how to handle or what to do with, and then not being afraid to turn it off if you realize it's actually not working or performing well in your institution. So I think there is pros and cons of sometimes taking these big models that are available out of the box from Epic. However, moving into one of the other things that Epic has had for a while in their AI toolkit has been the AI drafted replies to inpatient messages. I'm not an outpatient doctor, but I know our outpatient doctors are inundated by inpatient messages all the time, rightfully so. I send them myself to my own PCP. So Epic has released, automated replies to those AI messages. You can see that in some of the studies, it was only about 20% of the time they were actually using those draft replies out of Epic. And a lot of it had been because it doesn't know all of the patient's history. It doesn't say everything. But there has been studies that have shown that those chatbot replies are actually more empathetic than those busy, burnt-out doctors who don't have time to put empathy or care into those. So utilizing them, or if it works well for your system, can actually improve patient satisfaction and seeing some more empathy in some of those replies, which I think is very interesting. Okay, shifting to some AI tools in medical education, because this is a hot topic. In this day and age with trainees, how do we make sure they still know how to write a note when their ambient AI scribe could do it for them? And how do we help make sure they can, not over rely on some of these tools? So while looking back at our hype cycle curve, I suspect by the time our trainees are done or out, we will eventually make it into the plateau of productivity and knowing what are these AI tools useful for and how are they just automatically integrated into patient care. But I think the biggest article that, if anybody hasn't read it yet, is this New England Journal of Medicine article titled Educational Strategies for Clinical Supervision of Artificial Intelligence Use, which actually gave me new vocabulary that I hadn't even thought about in this era of things like de-skilling, mis-skilling, or never skilling. How do we make sure we put AI into the medical education and trainee at the right time so that the trainees still learn the skills they need to learn, like how to write a note, how to take an appropriate, patient history, but also use those tools to help them, have adaptive practice, which you can see up on the screen here, where the productivity goes way up. Maybe I can get my mouse back. That's okay. You can see that on the screen here. There's that time point of us making sure that we're never scaling, but still getting that practice in. Oh, I think this is where I see it. Yeah, there it is. Okay, good. So this is an interesting topic, and I think we're all still figuring it out. I think how hospital systems have approached this is very different. Some have released their ambient AI or their technologies for all trainees and medical students. Some only do it maybe after their second or third year. Some haven't given it to any of them. What I do and what this article talks about is I encourage them to practice using open evidence or some of these tools and then bring it back to round so we can talk about it. But I still encourage them, did you click on the articles? Did you read the primary articles they found for you and making sure you agree with what the AI assessment is, or you double check what you're finding and trying not to over rely on it, but still practice using some of those skills, some of those new tools, which then that means we also have to have practice using those tools to know, the pros and cons behind them as well. So Up to Date, which has been, I think one of the trainees tools that they've been using for decades now. It's also launching their expert AI. And I was one of the pilot members that was able to do this. And this is an example of what I said in Up to Date, talking about an infant with a rash from a food allergy. Can I use Benadryl? What I like about it for trainees is you can still see that it put the assumptions in, saying that we're assuming, I can give you the answer, but I'm assuming that this patient isn't having any respiratory distress. They're not in shock. They're not in the ER for other reasons. And these are the answers, which I still do like. While I think open evidence is a little bit stronger in the large language models for trainees, the Up to Date AI expert is still trying to give that same trainee perspective of these are the assumptions you're making. And so these are the answers I'm going to give you. So all of these new companies and technologies are trying to release their new AI features. Okay, now moving into ChatGPT or OpenAI. I've actually used this for my own research or doing research on a topic. There's a deep research tool. This was an example of looking at closed loop FiO2 control for neonates. But the point I wanted to make is that in 13 minutes, this reviewed 34 sources, gave me a table, gave me a summary of all of those sources. If I would have reviewed all of those 34 sources myself, it would have taken me days. So these tools can be really powerful in finding new articles, new things I hadn't read before, and giving me a framework for what articles do I need to read, what do I need to double check in my own research as well. So I definitely think starting again to use these tools to learn how to educate your trainees and the pros and cons of them is very important. Notebook LM, which is another free large language model, I find to be very powerful as well. This was the example of, I said, provide a 1 to 3 sentence summary of this talk. What am I going to talk about today? Notebook LM, you upload the resources you want it to review, and it only gives you answers based on those resources. And the other thing that's really powerful for trainees is you can turn it into an audio. So if you want to upload a paper and then you have a commute and you're driving, you can actually turn it into a podcast or an audio where it reads that paper for you. So it can be another great learning or education resource for people. Fellowship goals and objectives. This is an example to help me and myself. How do I be more efficient when I'm drafting a new rotation for my clinical informatics fellowship? I just put on all of these goals and objectives that I needed my fellow to learn from a cybersecurity rotation, and it created beautiful, objectives and subpoints for me to put into, what are the objectives for this course. So just another efficiency tool, something we can use for trainees and helping me not spend hours drafting these goals and objectives, but I can draft it for my trainees as well. Okay, in the last 10-ish minutes or 5 minutes, I'm just going to talk a little bit about Epic Cosmos. We have another session on this today, so I'm just going to really give a highlight for people to know what it is, since you guys are transitioning to Epic soon. But what is Cosmos? Cosmos is Epic's de-identified database that you have access to if you're an institution that has Epic and you're submitting data to Cosmos. So back in 2023, when I first started giving this talk, it had 203 million patients in it, which is one of the largest databases possible. Already, I took the screenshot like 2 days ago. It has 310 million patients in it. Billions of encounters, lots of hospitals, lots of physicians. So this is growing rapidly and is a very powerful research tool. You can query millions of patients in minutes. It does take some time to run once you get larger and larger databases, but it is fairly representative to the US Census, which I'll show you soon. And what's also really interesting is you can follow longitudinal charts. So even patients who were in Pittsburgh, but then moved to the University of Iowa, if we're both submitting data to Cosmos, I can see that data as they move different places. So historically, we would lose patients who came in and out of our studies, but as long as they move to another Epic Cosmos institution, we can still follow them, which is great for me doing neonatology research to answer that question of how do they do 10 years from now? What diagnoses do they get? What does that look like? So I think it's going to be a really powerful database for us to use. And you can see here, this is Cosmos versus the US Census. You can see based on age, race, ethnicity, coverage, it's very similar to the US Census. What it is a little bit is it has actually even more high-risk patients in it because many of the big academic large medical centers are using Epic now. So for your medical complex patients, you actually have that enriched in your Epic Cosmos database as well. So how do you get access? Belong to an Epic institution. Make sure your institution is submitting data to Epic. And then you as a researcher, you do have to sign up to take the Epic classes. There's the Cosmos Super User Badge, which you can use a slice or dicer version of Epic, which is kind of like giving you the graphs that I showed you. Or if you want to get to the line level data, which it's de-identified line level data, you can take more of the data architects or data scientist class to understand the background of SQL and how to pull that data out. So for the slicer dicer version, which is kind of the summary level data, you do actually have some limited data set information available, such as zip codes and age, and would actually even show you the state the patients are in. But then if you want to drill down to get more line level data of more demographic information about them, it does get more de-identified and you don't get the zip codes. I do think that they put the state back in because now there's enough hospitals in every state that you can't truly identify them just from the state. But instead you can do something like social vulnerability index or the RUCA codes to understand some more about that for the patients. Quick neonatology example of whenever you're using Cosmos, this table at the top is what I did in Cosmos for neonates. And this is, I, of course, am from Iowa, so went down to 21 weekers. These are just 21 weekers in Cosmos in general. It doesn't mean that they survived. But you can see that I compared the male, female birth weight examples to what I found in other published literature. This is from the NRN that was published. And I found very similar percentages in birth weight, male, female. So it made me feel confident that my cohort, my query is representative about what other national databases are reporting for the patients. And then this work is what I presented recently at PAS and XGM. And this is what we're seeing is I can use Cosmos to see what is the increased rate of active treatment in 22 weekers. And us in neonatology know it's going up. And I can see that over the Epic Cosmos databases, we are seeing it go up. The overall survival hasn't increased a ton yet. It's still only like 30-40% for those babies. And even here's our 23 and 24 weekers. Our 23 weekers are about 60% overall survival in Cosmos as well. So this is a fast and easy way that this data refreshes every 2 weeks in Cosmos that we could keep track and see how these overall outcome survivals are improving and changing over time. So best practices learned, this is my last Cosmos slide, and then we'll move to questions soon, is that, you have to be careful for using Cosmos data and really understand the ins and outs because the trends could change depending on how many people are on Epic submitting data to Cosmos. So what we have done is we've restricted sometimes our cohort to have people who are submitting data in Epic Cosmos over these 10-year periods that I'm looking at. So I can just see how that cohort has been changing over time. There are limitations in historical data. While there is some data going back all the way to 2013, there's not a lot of data there. The data seems to be better more around the 2018 time range for Epic Cosmos data. So have to understand that. And then not all the variables you may want are available in Cosmos yet. They keep adding more and more variables and they're taking our active feedback, but you just have to be careful and making sure that you have the variables you need and you understand the clinical implications of those variables. And some of the, these are just neonatology or maternal infant examples that we found. Okay, final slide, call to action about AI. Hopefully by the end of this talk, I gave you guys one quick pearl that you could use to start using a new tool now, whether it's open evidence, ambient AI, something, because I think we found that a couple of years ago, the expectation of AI was it was going to be robots taking over the world and, taking over our jobs. But I like to think that the reality is Bob Ross painting happy trees. I don't know how long I can use this Bob Ross analogy anymore, but I think these tools are to help, decrease our burden, decrease our cognitive load. Most institutions already have some sort of tools implemented, whether you've tried them or used them or not. I think we need to start trying because unless us as physicians start giving feedback or saying it doesn't work this way for neonatology or it doesn't work as well for inpatient, these tools won't get better. So we really need to have every division or department have that clinical champion. I've tried it out. This is the use cases we should use it for. This is what it doesn't work for, to really encourage all of us to be able to take advantage of all of these new technologies to help us decrease our burden and cognitive load. So with that, I'll pause and take any questions.